Hello, future nurses. This is Professor Flourish. Today we're going to be talking about Chapter 13, Concepts of Electrolytes. So before we start diving into the different electrolytes, I want to just kind of go over some general information about electrolyte imbalances. This is just some general information. Electrolytes are basically these charged ions. You can have some that are positively charged, like magnesium, potassium, sodium, calcium, and your hydrogen ions, or you can have them negatively charged, such as your phosphorus, your sulfate, your chloride, your bicarbonate, and proteinate. So these electrolytes can be distributed between the intercellular fluid and the extracellular fluid. The cell excitability is maintained by this interaction between the ICF and ECF, and it's all about that transmission of nerve impulses. So last week we talked about the sodium potassium pump. We're just kind of building on this whole concept here. And our body fluids should be electrically neutral. So our fluids itself should be neutral, but it's just these electrolytes that can cause that positive or negative charge. So on this slide, it just shows the expected reference ranges. And like I said, these ranges can change ever so slightly from facility to facility. So you might have one facility that's like 135 to 146 or 135 to 145, and it's still within that same range. So because of that, NCLEX now will just kind of give you the range, and then you have to figure out what you want to do. So my big suggestion when it comes to studying is understand what's associated with a low number, what's associated if it's abnormal. If I've got like a potassium of 2, then what are my care measures for this level of 2? The first electrolyte we're going to talk about is sodium. Its range is 136 to 145. And I've broken down these slides in such a way that basically we go through the normal process of sodium, foods high in sodium, and then we'll go into the hyper versus hyper issues, what you're supposed to do for that, and then just a general way to study for these ones. This slide here is just a general overview of sodium. So this is a major electrolyte found in the extracellular fluid and maintains that extracellular osmolarity. So water follows sodium. That's basically kind of what you want to remember with this, is that it's water flows into the direction of sodium concentration. The basic function of sodium is it maintains fluid volume, allows muscle contractions, and contributes to nerve impulses. And the reason I talk about these normal functions is because when you have two less of the electrolyte or two more of the electrolyte, it's almost like you see all these functions go either in one direction or the other. Sodium can influence fluid retention, excretion, and movement of fluid from one body space to another. Kidneys are your main regulator of sodium levels with the assistance of aldosterone, antidiuretic hormone, and once again, those peptides that we talked about with our fluid lecture. So these are some foods high in sodium, things like table salt, salami, ham, processed foods, beef broth, tomato juice. For the most part, we're usually trying to tell people to limit their sodium opposed to how to increase their sodium. So for the most part, we're telling them to avoid these things, to do things like avoid things like fried chicken. And if they're trying to have less sodium, give them something like grilled chicken because that has a lot less sodium than something like fried chicken. So kind of keeping that in mind whenever you're studying is yes, these are things that are high foods in sodium, but you also want to think about foods that are low in sodium. So the first thing we're going to talk about is hyponatremia, which is low sodium below 136. And I put a little picture of a brain on here just to kind of help you when it comes to remembering what happens with sodium imbalances. So hyponatremia, Na is what stands for sodium. Net gain of water or loss of sodium-rich fluids. Sodium less than 136. Hyponatremia is that delay or slowing of depolarization of membranes. So that goes back to that active transport system. Water moves from the extracellular fluid into the intercellular fluid. Cells basically swell and you get cellular edema, typically caused by fluid imbalances, which result in sodium loss. And basically, the way that this compensates for itself is kidneys will excrete some of that sodium-free water. So your kidneys are going to get involved with your sodium imbalances. So there's two different kind of assessment or risk factors that you can see with this. And your book does do a good job. And with some of the later electrolytes, I literally like copied it from the book just so you guys can get a view of what it looks like in the book. But your book does do a good job of kind of splitting up the actual sodium deficits versus relative sodium deficits. So you really kind of have to think about this because both these patients look very different, but they're both suffering from low sodium. Actual sodium deficits are the body has a true loss of sodium. For this patient, that means that they are just lacking sodium. Then you've got relative sodium deficits due to dilation. So basically what happens is the body's sodium content appears lower related to having diluted blood. So basically what's happened with this patient is they have so much blood on board that it makes them appear as though they're hyponatremic. So you just kind of have to kind of keep these two separate because the etiology behind my sodium loss is going to be different. For somebody who has true sodium loss, they're probably just going to give them a sodium pill. For somebody who has a sodium deficit due to dilation of their sodium, they might do something like a diuretic. So just kind of keeping in mind what's going on with your patient. So here are the actual sodium deficits: excessive sweating, diuretics, because remember, with a lot of your diuretics, you can end up losing a lot of that sodium. Wound drainage, nasogastric tube suctioning of isotonic gastric contents, decreased secretion of aldosterone, hyperlipidemia, kidney disease, inadequate sodium intake, hyperglycemia, low sodium diet, or cerebral salt wasting syndrome. This is a continuation of our risk factor. These ones are the relative sodium deficits related to dilation. So what you have on here is hypotonic fluid excess, freshwater submersion accidents, so drowning in fresh water, kidney failures or nephrotic syndrome, heart failure, syndrome of inappropriate antidiuretic secretion, basically any of your SSRs. Older adults are at risk related to increased chronic illnesses, use of diuretics, and risk of insufficient fluid or sodium intake. Now with this, the one I really want to talk to you all about is this rapid IV infusion of D5W, 0.45% sodium chloride. So this is basically the rapid IV infusion of a hypotonic solution. And what I want to talk to you about with this is when you give somebody a hypotonic solution, especially like, well, not just especially, but when given to even a healthy patient without any blood imbalances, the hypotonic fluid can dilate their bloodstream, which can lead into this electrolyte imbalance. So you have to watch your patients, especially if there's somebody who's younger. So if you've got somebody who's like 25 or even like 35, you want to watch them and make sure that you're not just giving them a hypotonic solution all the time because it can cause an imbalance within their vasculature. Because remember, these hypotonic solutions, the fluid usually goes into the cells, which is going to cause them to not be at the same rate everywhere else in their body. So just be aware of what fluids you're giving people. So expected findings, this is some more of your assessment data. Your assessment data depends on the extracellular fluid. Remember, sodium lives in that extracellular fluid. So you have to always ask yourself, is it normal? Is it decreased? Or is it increased? So do I have hypovolemia or do I have hypervolemia? So these are some of your vital signs with hypovolemia. So you'll have hypothermia, tachycardia, rapid thready pulse, hypotension, orthostatic hypotension, and diminished peripheral pulses. So remember your fluid lecture. If the patient is hydrated, resulting in low sodium, then your patient will have signs and symptoms related to dehydration. So just also associate what's going on with that hypovolemia, because you can have some patients that are have very low fluid and they also have very low electrolytes, and they're showing all these similar symptoms as dehydration. And I highlighted tachycardia and hypotension because you always want to watch for these two signs. Is my patient potentially going into shock from lack of fluids? Now, with any of these vital sign changes, you want to ask yourself, what can I do as the nurse when I see these? So my patient is hypothermic. What can I do that's the least invasive thing that I can do? I'm going to get them a towel sorry, I'm going to get them a blanket, or I might turn up the heat by a degree or two. My patient is tachycardic. What can I do to kind of lower their heart rate? That's something that I can do. Maybe I'm going to turn off the lights, try to put them in a position where it's a little bit more relaxing. Orthostatic hypotension. If I know that they have orthostatic hypotension, am I just going to have them jump up out of bed? No, I'm going to try to get them to slowly move up, or I'm going to talk to physical therapy whenever they get them up to make sure that it's a slow process. So you just kind of want to be aware of your vital signs and how you're treating the patient. Now, the next one is you're hypervolemic with hyponatremia. So this means that my blood is very dilated. I've got a lot of fluid, but very low sodium. So this is those ones that maybe I gave them too much of a hypotonic solution, and now I've got a patient that has very diluted blood. So for them, you're going to want to once again remember your fluid lecture. If your patient is overhydrated, resulting in low sodium, related to dilation, then your patient will show signs and symptoms related to overhydration. So just kind of think about what's going on with your patient. And the other thing, just as a good rule of thumb when it comes to answering some of these NCLEX questions, is when you're reading it, understand what you've already assessed. If you see something like you've assessed their levels and you see that your patient is 134. You see that your patient is 133. At that point, you've basically just read it on the computer. The next thing you need to do is go lay eyes on your patient. Now, if you're laying eyes on your patient within the question, then the next thing you want to do is some sort of intervention. So just kind of just be mindful of how you're reading these questions. What am I doing within this question? What is my next step within this question? And try to think of it as much as you can to what you would do in a normal setting. Now, like I said, this is hypervolemia with hyponatremia. So since this is hypervolemia, I'm thinking fluid overload. So my pulse is usually going to be pounding. My blood pressure may be within or above expected ranges. So that's a very different picture than the one we had with my patient who was hypovolemic. And then here we've got some more assessment data. We've got our neuromuscular. This is why I said when you think of hyponatremia, when you think of sodium, always think of your neuro because what did sodium do? One of the things it did was help with our nerve impulses. So neuromuscular, headache, confusion, lethargicness, muscle weakness to the point of possible respiratory compromise, fatigue, decreased deep tendon reflexes, seizures, lightheadedness, and dizziness. By far, one of the main things you're always worried about is sodium in brain. So you just really want to watch these patients for changes in their level of consciousness. Gastrointestinal, increased motility, hyperactive bowel signs, abdominal cramping, and nausea. So these are my laboratory tests. My blood sodium is going to be decreased less than 136. So it's going to be a lower number, and that's where we get that usual range. When we talk about these ranges, we're usually talking about the blood sodium. Blood osmolarity is also going to be decreased. Your urine sodium, now this is where it gets kind of difficult, and you have to think about this, is if it's due to just lack of fluid, lack of electrolytes, it's going to be less than 20. However, if it's due to dilation, it's going to be greater than 20. My urine specific gravity is going to be decreased in sodium loss and then greater than 1.012 in dilation. So you really need to kind of make sure that you're keeping it separated of is this hyponatremia due to lack of sodium or is this because it's so diluted it appears like it has a lack of sodium. So these are just some memory tools that I put for your signs and symptoms. Salt loss, because I found that to be one of the easier ways to remember it. I saw it on one of those helpful guides for how to remember things for NCLEX, and I just thought it was easy because if you think about it, salt loss, What is usually the main problem with hyponatremia? Some sort of salt loss, whether it's due to I've got so much fluid that I have low salt, or because I have a true loss of salt. So with this, we've got stupor slash coma, A for anorexia, L for lethargicness, T for tachy weakness cardia, so that thready pulse, L for limp muscles, muscle weakness, O for orthostatic hypotension, S for seizures, S for stomach cramping. So that's just an easier way to think about these signs and symptoms of what's going on with your patient. So now that we've seen our risks, the next thing we're going to talk about is our interventions. So PO intake, if they don't have enough sodium, I can give them sodium. IV fluids, you just have to be careful with your IV fluids because like we talked about before, if you have a healthy patient that's NPO, I give them a bunch of hypotonic solutions, I can accidentally put them into hyponatremia. So a lot of times it's more of your isotonic solutions that can fix this problem. Like I'm going to give them 9% fluid if it's just due to dehydration, or I'm going to try to give them something to give them fluid or to give them sodium. Now, be very, very careful with how quickly you replace sodium because basically you can cause very bad neuro problems if you give it too quickly. I know for us, like back when I had to give sodium to patients or when I've given sodium to patients, it's like a super, super slow process. Like I think the lowest, or one of the ones I remember is we had a patient who was very, very low in it, and you're basically moving it up by a degree or two because you don't want to suddenly cause them to go into this neurological damage state. For fluid overload, you're going to restrict fluids. Once again, we're getting back to our fluid lecture where we're going to do things like I's and O's, watching their weight, vital signs, and that level of consciousness. So, who are we going to talk to about this problem? Nephrology, respiratory, and then nutritional support to find things that are high in sodium. So, what do I teach my patients? I teach them to weigh themselves daily, instruct them to consume a high sodium diet, to keep a record of their sodium intake. So this is another memory tool of what you can do for for entertainment. For interventions, it's just called add salt. So add A, administer IV sodium chloride infusion if due to hypovolemia, D, diuretics if due to hypervolemia, D, daily weights, S, safety, A, airway protection, because once again, this is a neuro problem, so we want to protect our airway. These patients, we might end up putting them as NPO until we can get them out of that confused state. L, limiting water intake, and T, teaching. So that's just another memory tool that might help you out. Once again, some of our complications can be things like coma, seizures, respiratory arrest can occur if acute hyponatremia is not treated immediately. So some of our actions for the severe hyponatremia elevate the sodium level enough to decrease neurological manifestations. But what I will say is, once again, you can't raise it too quickly. Maintain open airway, implement seizure precautions. Why are we going to implement this? Yes, safety is a huge concern. We always want to look at safety first. What can I do to make my patient more safe? Monitor your level of consciousness, administer hypertonic oral and IV fluids as prescribed. So the hypertonic solutions, the reason for that is because a lot of these are very, very salty material. So we're going to try to get them their salt back. So that's that 3%. You want to administer 3% sodium chloride slowly and always monitor their levels frequently and get a baseline of vital signs prior to administration. I can't stress this enough. Before you give any sort of hypertonic solution, always make sure you know what their blood pressure is. Because it's like I told you guys during the fluid and electrolyte lecture. Hypertonic solutions are basically like these super diuretics because they squeeze out all the fluid from the intracellular space. And when they do that, patients' blood pressures can drop. So I want to know what their blood pressure is before I use it, and I want to administer this very slowly. All right, this next one we're going to be talking about is hypernatremia, which is sodium that's above 145. So, just as an overview, increased sodium causes hypertonicity of blood. This causes a shift of water out of the cells, resulting in dehydration. Because remember, water flows where sodium goes. So, all of that water is moving from out of the cells out to follow this water. Sodium or blood sodium level is higher than 145, and it can cause significant neurological, endocrine, and cardiac disturbances. So, what are some of my actual sodium excess issues? Things like kidney problems, Cushing syndrome, aldosteronism, some medications such as glucocorticoids, and excessive intake of oral sodium. What does it do to decrease fluid volume? Water deprivation, so things like NPO, hypertonic, tube feeding without adequate water, diabetes insipidus, heat stroke, hyperventilation, watery stools, burns, and excessive sweating. What are some of my expected findings? Thirst. When you have a lot of sodium on board, your patient begins to feel very thirsty. It's like when you eat very, very salty food. Vital signs, hyperthermia, tachycardia, orthostatic hypotension. With them, they're going to have restlessness, irritability, muscle twitching to the point of muscle weakness, including respiratory compromise, decreased or absent deep tendon um, reflexes, seizures, and a coma. The blood sodium is going to increase greater than 145. Blood osmolarity is going to increase to greater than 300, and your urine specific gravity and osmolarity is also going to be increased. Another memory tool is this fried salt for people that are very hypernatremia. So with fried salt, it's that flushed skin, restlessness, increased blood pressure, fluid retention, E for edema, D for decreased urine output, S for skin, A for agitation, L for low-grade fever, and T for thirst. Because remember, if we're very, very salty, we're going to be very, very thirsty. Next, we've got some of our interventions. And with these, like I said, when you think of your sodium problems, think of brain problems. So you want to monitor that level of consciousness and you want to make sure that they are safe. If they've got orthostatic hypotension, make sure they're not just suddenly jumping up. Monitor your vital signs, your heart rhythm. Also take your lung sounds. Provide oral hygiene and other comforts to decrease and manage stress. You want to monitor your ins and outs, and then make sure you're alerting the physician if there's any inadequate urine output. And with excessive sodium, encourage water intake and, discourage any sodium intake and administer those diuretics if needed. So hypernatremia related to fluid loss. So this means that for some reason I'm losing straight fluid. I need to do something in order to fix my sodium balance. So the types of fluid that you usually use are things like your hypotonic solutions, dextrose, or that 0.3% sodium chloride, which basically provides a more gradual reduction in blood sodium levels and reduces the risk of cerebral edema and is preferred to patients also dealing with hyperglycemia. And then you can also give them isotonic solutions. So for hypernatremia, I'm thinking of more hypotonic and isotonic solutions. So what are some of my complications? We can have things like convulsions, seizures, and even death. So for us, our big nursing interventions, maintaining that airway. I want to make sure that I have an open airway, checking my vital signs, seizure precaution. Once again, I'm always worried about safety and monitoring that level of consciousness. So on this slide, it's basically an example of how you can break down these sodium imbalances. I've got two little cards here. I've got one card that shows signs and symptoms, and then another card. Because if you're trying to design your flashcards or however you do it, I found that this is a much easier way because it basically has everything that you need to know about these imbalances without having it too much. Because the idea behind it is you want to think about a way that works for you. That's the easiest way that you can look at it and be able to know without a doubt, okay, hypernatremia, signs and symptoms, fried salt, hyponatremia. So low sodium is things like salt loss. So I kind of tried to color code it too for those of you guys that like color, but I hope that this one helps. And once again, and I put like little pictures on it because I'm kind of a visual person. So I have the sodium imbalance, think brain, and then I've got all these kind of signs and symptoms here for it. So the next we're going to talk about is our potassium. And remember, whenever sodium goes up, potassium goes down, and vice versa. Whenever potassium goes up, sodium goes down. So whenever we're kind of like rehydrating somebody and we're using some of these solutions, especially if it's like something like a hypotonic solution or even just an isotonic solution, we always want to think about the effect. Like if all of a sudden I make my sodium go up, my potassium is going to go down. If all of a sudden I'm giving something that's going to make my potassium go up, my sodium is going to be down. So you just want to always think about, whenever I think about sodium, I also want to think about potassium. Because these two, especially when we're messing with our fluids, are the ones that are the most affected and they're the ones that we're the most concerned about. Sodium, it's with my brain. Potassium, it's with my heart. So the following slides, we're just going to be talking about these potassium imbalances. So overview, potassium K plus. If you see K, vitamin K is different than K plus. So make sure that you know that K plus equals potassium. So it's one of the major electrolytes that's in the intercellular fluid, and 98% of the body's potassium is within the cells. So function, it plays a vital role in cell metabolism, transmissions of nerve impulses, functioning of cardiac, lung, and muscle tissues, and acid-base balance. Minor variations in the level of potassium in the body is a significant finding. So whenever you think of potassium from here on out, always be thinking about your heart and these kind of muscle weaknesses along with it. We're very, very concerned about minor changes. Like I said, it also general function is it maintains fluid volume inside the cells, muscle action. And since your heart is a muscle, it's going to also affect that heart. So these are my foods that are high in potassium. We've got oranges, dried fruits, tomatoes, avocados, dried peas, meats, broccoli, bananas, dairy products, whole grains. And you also want to look for any hidden signs of potassium, which is AKA salt substitutes. So that no salt salt. Because what they essentially do for no salt salt is instead of using sodium, they use potassium. And what I will say is NCLEX knows that a banana is filled with potassium, so they always try to kind of trick you. I don't want to say trick you, but they always try to get you to look at alternative things. So instead of saying a banana, they might put an avocado, or they might put something like a dried fruit. It's just something other than using the word banana. And whenever they're trying to get you to know to look for potassium, they'll use things like that no salt salt, any sort of salt substitute. So with this, we're going to be talking about our hypokalemia. This is low potassium, less than 3.5. And what I will say is, whenever you're thinking about these assessments, um, always look for the thing that's going to kill your patient first. Is no matter what my electrolytes are, first thing I want to assess is their breathing. Because a lot of these electrolytes, when they become imbalanced, the heart will be affected first, but then it can lead into things like breathing problems. So you always want to make sure that you're going to assess their respiratory rate, their rhythm, their depth, everything that's going on there, and then you go on to everything else. Because my patient needs to be breathing, and then I can check their heart, I can check everything, their blood pressure, and all that jazz. Okay, so some of the risk factors of actual potassium loss are overuse of diuretics, digitals, and corticoid steroids, increased secretion of aldosterone, Cushing syndrome, loss via GI tract, vomiting, diarrhea. Honestly, whenever you have a patient that's having a whole lot of diarrhea, make sure that you're watching them for any fluid imbalance as well as these electrolytes, because they can lose quite a bit of potassium with it. Prolonged nasogastric suctioning, excessive use of laxatives or tap water enemas, NPO, and kidney disease. Kidney disease basically impairs the reabsorption of potassium, thus makes it so they cannot get that potassium they need. So some of your relative potassium deficit risk factors are alkalosis, giving them too much insulin, which is that hyperinsulinemia. Hyper alienation is basically giving them too much TPN, water intoxication in older adults due to that increased use of diuretics and laxatives. So, what are some of my expected findings? Decreased blood pressure, that thready, weak pulse, orthostatic hypotension. Because remember, potassium affects muscles. What muscle do I care about more than all the other muscles? My heart muscle. Neurogenic can have altered mental status, anxiety, lethargicness that progresses to acute confusion, coma, as well as fatigue. ECG, flattened T waves, prominent U waves, ST depression, prolonged QR intervals. Gastrointestinal is going to be hypoactive bowels, nausea, vomiting, constipation, abdominal distension, paralytic ileus can develop, muscular weakness, deep tendon reflexes can be reduced, and respiratory is shallow breathing. So looking at this, let's say that you are at the hospital. First thing you do is check your patient's labs while you're waiting to get report, and you notice that your patient has a potassium of 2. From there, the next thing you want to do is immediately go to that patient when you get a chance. Well, more than when you get a chance. Go to that patient, assess how they're breathing. Because remember, with our ABCs, we want to always check how they're breathing. So from there, you see that they've got that shallow breathing. Let's say we end up calling a rapid. From that, we get some um, dosing for some potassium to give them orally, and the patient's finally getting back. They're getting better. So a positive sign that they're getting better would be something like their breathing goes back to normal or they've got decreased fatigue. So that's where I say, like, these expected findings that you'll see with them, you also want to see when the patient gets better. And how do we know if the patient's getting worse? Is our treatment actually working? Always ask yourself that whenever you're studying and you look at this assessment data. Don't just study the assessment data, also ask yourself, how do I know if my patient's getting better? If I have shallow breathing, how do I know that it's gotten worse? How do I know if it's gotten better? Diagnostics is blood potassium is decreased to less than 3.5. And on your ECG, it's going to be that inverted or flat T waves, ST depression, and an elevated U wave. Now, with this, I know we haven't gone through cardiac yet, but it is good to know what these actually look like. You want to know what my ECG is going to look like so that way you can be aware that they might have a potassium problem. And low potassium looks different than high potassium. And on the next slide, this picture looks a little bit more in depth, so we'll look at that in the next one. So I really, really like this picture here, mostly because it shows you what it looks like if the patient has normal potassium versus hypokalemia versus hyperkalemia. So with the normal, we've got a beautiful QRS, we've got a wonderful T wave, everything looks the way it should. And like I said, we'll get into more with our ECGs as we continue on in the semester, but this is just a good rule of thumb because your QRS is basically telling us what our ventricles are doing. Our PR is kind of telling us what our atrium is doing. So on here, what you can see with somebody who has low potassium, they're just visually, you can see that ST depression, and then all of a sudden they've got a U wave. So those are the two things that you're kind of looking for that you can say, okay, just visually I can see. So let's say that you're working as charge nurse and you're looking at all the monitors and you notice this, then you can think to yourself, okay, my patient probably has hypokalemia. Then we get into hyperkalemia, which we'll talk about more when we get into that electrolyte. But this one, this looks completely different than the normal look of what an ECG should look like. So this one, they're going to have that tall peak T wave. And since this one's getting more into a medical emergency, yes, you absolutely want to know what this one looks like. Okay, so what are my interventions? I know my patient has low potassium. How am I going to fix it? I'm going to give him potassium. Now, one thing I will say is you never, ever, ever, never, never, never give it IM or subcutaneous because you can destroy the tissue. Once again, it's one of the few times I say never. So do not give it in these two ways. Oral and IV are okay. Just be mindful that this is a very large pill, so you want to watch your patient actually take it because sometimes people can choke on it. Monitor and maintain your urine output. Assess for shallow and ineffective respirations and diminished breath sounds, monitor your cardiac rhythm, watch patients on digoxin. It can increase the risk of digoxin toxicity. So looking for things like that yellow vision or nausea with them, and then monitor your level of consciousness. You want to watch your patient's safety, monitor their bowel signs, and abdominal distension, intervene if needed. You want to monitor their O2 sat, assess their hand grips for muscle weakness, because once again, potassium affects the muscle. So you want to make sure that you're watching these patients for any changes in muscle strength. So assessing your deep tendon reflexes and implement precautions if they're having a lot of weakness associated with these muscles. So oral replacements. I basically just copied that same slide from before. You want to encourage foods high in potassium. Remember, NCLEX isn't going to always just straight up tell you a banana, so you got to think outside the box. Things like melons, citrus fruits, broccoli, avocados, anything of that nature. And if all else fails, we can give them an oral medication. IV potassium supplementation. So once again, you are going to see me say never. Never administer by IV bolus. It's a very, very high risk of cardiac arrest. If you get nothing else from nursing school, remember to never push the potassium. Maximum recommendation rate is 10 milliequivalents per hour, with a concentration of no more than 1 milliequivalent of potassium per 10 mLs of solution. I don't care how much of in a hurry you are, you never push this like too quickly of potassium. Um, now that being said, it's one of those things that NCLEX loves to ask you about this in a way that's who needs review or who do we need to recorrect when we're talking to a patient. And it's usually that person who's trying to push the potassium. So just make sure that you're watching that you're not giving it too quickly. Assess for phlebitis, so that's any tissue irritation. A lot of times potassium is very hard on the veins, so you just want to make sure that you've got a good access when you're giving them IV potassium. So for our interprofessional care, we've got nephrology, respiratory, nutritional services, and cardiology. Because once again, since it affects the muscles, it affects the heart. I care about the heart the most. So if I accidentally go from hypokalemia to hyperkalemia, I definitely want cardiology on board. What are some of our complications? Some of our complications can be respiratory failure. That's why I said if you've got a patient who's got hypokalemia, you want to watch their respiratory. So you want to maintain an open airway, monitor level of consciousness, monitor for hypoxemia, assist with possible intubation and mechanical ventilation if needed. And then our other complication would be cardiac arrest. So you want to perform that continuous cardiac monitoring and treat dysrhythmias promptly. These are just some reminders. Your potassium and sodium are opposites. So when potassium goes down, sodium goes up. So watch for your signs and symptoms of hyponatremia. So the next one we're going to talk about is hyperkalemia. So this is high potassium level greater than 5. It can result from increased intake of potassium, movement of potassium out of the cells, inadequate kidney excretion, so potassium level greater than 5, and it's rare in patients with normal kidney function. Who's at risk for actual potassium excess? Older adults related to decrease in renin and aldosterone and increased use of salt substitute, ACE inhibitors, and potassium-sparing diuretics. Overconsumption of high potassium foods or salt substitutes, excessive or rapid potassium replacement, red blood cells transfusion, adrenal insufficiency, ACE inhibitors or potassium sparing diuretics, and kidney failure. Some of your relative potassium excess can be caused by extracellular shift caused from decreased insulin production. Because remember, insulin works as that little key to open up the cells. So if I don't have the key, then I am at risk for um, hyperkalemia. That's why people who go into really bad stages of hyperglycemia, like people in diabetic ketoacidosis, You also have to be looking at their potassium levels. You have to be looking at everything that's going on with them electrolyte wise. So the next thing is your acidosis, like I was talking about, tissue damage, so sepsis, trauma, surgery, fever, myocardial infarction, and then hyperuricemia. So some of your vital signs can be slow, irregular pulse, hypotension, and I put oh no next to the things that are like the deadly things that you're very worried about. Because a good rule of thumb is when you're studying, kind of start with the things that's going to kill your patient first and then move down to everything else. Neuromuscular restlessness, irritability, weakness to the point of ascending flaccid paralysis or paresthesia, so basically numbness or not being able to move my muscles. ECG, premature ventricular contractions. And what I will say about the ventricular contractions, anytime it's a ventricular contraction, those are your deadly contractions. So we get very worried about things like VTAC, VFib, peak T waves and widened QRS. You don't want a widened QRS. That's a very bad sign. So that's why I say this electrolyte is associated with death. It's one of the ones we worry about probably the most. Gastrointestinal, increased motility, diarrhea, hyperactive bowel signs, and other manifestations for the kidneys are going to be things like alloguria. So the memory tool I have on here is hyperkalemia, murder, muscle cramps and weakness, U for urine abnormalities, R for respiratory distress, D for decreased cardiac contractility, decreased heart rate, decreased blood pressure. Um, E for ECG changes. These dysrhythmias will kill your patients. If you don't learn anything else again, dysrhythmias with hyperkalemia is a big thing. And R reflexes for increased deep tendon reflexes. So your lab and diagnostics, blood potassiums is increased past 5. Hemoglobin hematocrit increased with dehydration, decreased with kidney failure. BUN and creatinine is increased in kidney failure. Your arterial blood gases, metabolic acidosis with kidney failure. And your big oh no sign, electrocardiogram, we're looking at those tall peak T waves. So those are definitely a huge complication for your patients with hyperkalemia. There it is again, the visual of seeing that tall peaked wave. I mean, it just looks abnormal when you look at it. So on here we've got our interventions. A lot of times the priority is of course, safety, assessing cardiac complications, and health teachings. So you want to make sure that your patient is you're monitoring their heart, monitoring those cardiac rhythms. You're watching for those tall T peaked waves, monitoring your I's and O's, assessing for muscle weakness, observing for GI manifestations, and watch your labs. If a patient is receiving infusion for potassium, stop. Talk to your team. If patient is taking oral potassium, stop. This is why I said potassium is one of those ones, it's just one of those labs that I always look at first. I want to see how they're doing before I ever give potassium because I don't want to make it worse. Now, on the flip side of this, make sure you're also monitoring for hypokalemia while they're receiving the medications, monitoring your potassium levels, and severe hyperkalemia may require administration of calcium gluconate, and chronic or severe hyperkalemia may require dialysis. So another intervention is the promotion of movement of potassium from the extracellular fluid back to the intracellular fluid. So what you're going to do is administer IV fluids with dextrose and regular insulin. So asking yourself, why am I giving the dextrose with insulin first? Because insulin's going to drop their sugar count. And if it's going to drop their sugar count, I want to give them sugar. So dextrose is your sugar that you're giving them. Now, with that, what is my insulin going to do? Remember I said insulin works as that little key? So essentially what it's going to do is open up the cells, and when it opens up the cells, all that potassium should theoretically go back into the cells and will fix our problem. And this is especially with people who have hyperkalemia. So if I got somebody who's like 6.5 hyperkalemia, I want to give them insulin with dextrose in order to lower that. You can also administer sodium bicarbonate in order to reverse that acidosis. How can I prevent hyperkalemia? Avoid foods high in potassium. Do not give potassium to patients receiving potassium conserving diuretics. And you can also leach your vegetables. So it's possible to reduce the content of potassium by slicing, peeling, soaking overnight, or draining the water and boiling the vegetables. So some of my medications for hyperkalemia might be a loop diuretic. So if my kidney function is fine, I can give that to them and it increases the depletion of potassium. Sodium polystranium sulfate, so works in the intestines and excretes excess potassium through feces as well as insulin. So all of these, I can either lose it through my urine, lose it through my bowel, or I'm going to open up the cells and move some of that potassium into the cells. So we're going to call nephrology, our nutritional services, and our cardiologists if we've got a patient who has very severe hyperkalemia. Complications, cardiac arrest. So if we don't do anything, these patients are at risk for having that wide QRS and having cardiac arrest. So you want to watch them very closely. Once again, very similarly to my sodium imbalances, I've got these two little cards here that you can kind of look at that might be able to help you when you're trying to organize your own thoughts for this. Same thing here, it's got management, it's got everything to kind of put together however you feel you want to study for it. So the next thing we're going to talk about is our calcium. The normal level for calcium is 9 to 10.5. Calcium and phosphorus are both the major mineral contents of the bone. Vitamin D facilitates the absorption of calcium from the gastrointestinal tract into the bloodstream. And when the plasma calcium level is low, the parathyroid hormone is stimulated. When the plasma calcium is high, the parathyroid hormone is inhibited. So whenever I think of the parathyroid hormone, I always think of calcium. Calcitonin is a hormone produced by the thyroid. It acts at the bone and kidneys to remove calcium from circulation. There is basically an opposite effect again between calcium and phosphate. So when phosphate goes down, there's an increase in calcium, and vice versa. If calcium goes up, there's a decrease in phosphate. So here's where I was talking about in your book. All these little boxes are very helpful because we've got our risk factors here that show actual calcium deficit versus relative calcium deficits. Another thing to look at is this patient-centered care. For this one, it's the gender health, and what it says is postmenopausal females are at risk for chronic calcium loss. This problem is related to the reduction in weight-bearing activities and a decrease in estrogen levels. As females age, many decrease weight-bearing activities such as running and walking, which allows osteoporosis to occur at a more rapid rate. In addition, the estrogen secretion that protects against osteoporosis diminishes. Teach older female patients to continue walking and other weight-bearing activities for their overall health condition allows. So a lot of times this is why with your older female, especially postmenopausal, or if you have a male patient that might be on some sort of estrogen, because sometimes if you have a patient who had their prostate removed, but they still have remnants of prostate cancer, they'll put them on doses of estrogen. You want them to make sure that they're getting their bone scan. So just making sure that you're watching patients that they're taking care of their bone health. So with hypocalcemia, and make sure whenever you're studying this that you're not confusing it with hypokalemia. So you're looking for that C for calcium. So this is a blood level less than 9. Symptoms can be basically feeling this numbness around the mouth, hands, and feet. So that paresthesia, muscle spasms of the face, laryngeal spasm, and by far the biggest two symptoms that you're just always going to be asked about is this Trovosky's. So making sure that you know this C and T symptoms. Seizures, hypotension, arrhythmias, chronic hypocalcemia causes bone pain, and makes the bones very fragile, dry skin and hair, cataracts, depression, and dementia. And both of these are signs. So if they have these signs, so if it's like a positive Travasky sign, I'm very concerned about their calcium because these are the key signs for hypocalcemia. And basically, it's like if I rub the side of my cheek, their patient will have this like kind of like smile and it looks like this. If I put a blood pressure cuff on the arm, it kind of twists inwards. So interventions, I'm going to give them PO or IV calcium replacement, possible medications to decrease nerve and muscle responses, give foods high in calcium and safety. Remember, their bones are going to be much more fragile. So our next one is hypercalcemia. So we've got an actual calcium excess and relative calcium excess. So a relative would be things like hyperparathyroidism, because remember with the parathyroid hormone, I always think of that being associated with calcium. Calcium level greater than 10, common causes hyperparathyroidism, cancer. Symptoms are that increased blood pressure, full pounding pulses, muscle flaccidity, weakness. So you're looking at a difference between muscles that are overactive in hypocalcemia to underactive in hypercalcemia. Decreased motility, high calcium concentrations in urine, um, dulled consciousness, lethargicness, diminished or absent deep tendon reflexes, anorexia. Interventions: discontinue Ringer's lactate, discontinued calcium-based antacids, discontinue thiazine diuretics, give phosphorus, because remember, they work opposite of one another, calcitonin, because once again, that's going to force the calcium back to where it needs to go, aspirin. Fluid, normal saline, sodium, increased kidney secretion of calcium, and cardiac monitoring. Remember that with if you've got a very high level of calcium, like if you got like a level of 15 or just above that level of 10.5, then you want to be watching your patient's heart rate. And that goes back to your ABCs, is you always want to look at your airway, your breathing, your heart, because these electrolytes can affect all of those areas. Once again, this is that kind of breakdown of everything we just talked about. Um, as you can see with hypercalcemia, it can cause cardiac arrest, muscle weakness, opposed to the opposite side that's going to have that muscle spasms, things like stridor with respiratory. And stridor is one of those like very deadly signs. If you see stridor, that's an alert that something's wrong is happening. This is a continuation. I have like the parathyroid equals calcium, because that's the one that's going to help increase the level of calcium in the blood. Next, we've got phosphorus. So normal level of phosphorus is that 2.5 to 4.5. It's essential component of the bone, red blood cells, formation of ATP, acid-base balance, cellular building block. Hypophosphatemia, decreased intake, increased excretions. So for them, what you'll see sometimes is decreased cardiac output, slowed pulses, shallow respirations, weakness, and decreased deep tendon reflexes. And if you think about it, the way I always think about this one is if you think about what hypercalcemia looks like, that's what hypophosphatemia is going to look like. Because remember, they're opposites of one another. When my calcium goes up, my phosphorus goes down. Hyperphosphatemia, level of 4.5 or greater. The most common cause is kidney failure, and it's usually accompanied by hypocalcemia, and many of its symptoms are related to low calcium levels. Right, so we've got magnesium. Magnesium is a mineral essential for healthy muscles, nerves, bones, and blood sugar levels. These are your risk factors. For hypo, it's things like starvation. For hyper, it can be things like too much IV magnesium replacement. And you just kind of want to think about who's at risk for these. So who would be at risk for malnutrition? your older adult that might not be remembering to eat, so they might be very malnourished. And anybody above the age of 65 is considered an older adult, so making sure you're watching them for appropriate nutrition. With hypomagnesia, fewer than 1.3, magnesium is stored in the bones. It's caused by chronic alcohol abuse, prolonged diarrhea, laxative, increased renal excretion, sepsis, burns, and severe wounds. Some of your symptoms are going to be things like tachycardia, hypertension, shallow respirations, neuromuscular manifestations such as tetany, Chavaskay's sign, seizures, hyperreflexia. More serious manifestations are going to be things like respiratory muscle paralysis, complete heart block, and coma. Others can be possible depression, apathy, or agitation. And switching gears here, we've got hypermagnesium. And with those, it's a blood level greater than 2.1. Most common cause is kidney failure, and they've got the opposite of your hypo. We've got bradycardia, hypotension, hyporeflexia, muscle weakness, drowsiness, and severely high magnesium levels can also cause cardiac arrest. So on here, I've got some little tips like your magnesium, calcium fall and rise together. So that's why a lot of these signs and symptoms are going to be very similar to what we saw in our calcium lecture. And if you also think of magnesium as a sedative, you're going to have low energy, low heart rate, low blood pressure. So just kind of ways to remember it. And this is just the continuation of that. Well, that's everything. I hope this was helpful. Thank you all.